you.
Wonderful. Thank you so much. And we are really excited to be here today. I'm Terry Gerke with the Kentucky Diabetes Network. I'm the executive director, and I also sit on the committee for the Kentucky Diabetes Prevention and Control Program. We have a STEM initiative going on right now, which is a state management. We're looking at the employers and how we can increase participation in diabetes prevention programs. I'm really excited to be able to present this information, and I'm even more excited to present with Patricia Benson. Patricia and I went to grad school together years ago, and we've stayed in contact those last couple of years. We know it's more than a couple, but we stayed in contact, and she has run an incredible program with the University of Louisville today. So she serves as the co-lead on the STEM initiative with me, and I'm really excited. I'll give her just a few minutes to introduce herself, and then we'll get started on our content.
Terry, thank you so much, and I'm very excited to co-present with you as well today. Thank you, everybody, for joining us, and I think Terry gave you a pretty good introduction. I am now doing population health management work as a consultant. My experience is pretty vast in working with other companies and building a culture of health and well-being in the campus, community, and corporate environments. And one of my favorite quotes that I'm going to talk about today is replacing health eroding behaviors with health promoting ones. And so just remember that quote. I'll be going back to it today. Because it is the microscopic behaviors that you do day in and day out that contribute to your overall wellness or disease state. So on that note, one of the things we'll be looking out is how those behaviors may contribute to your risk of developing type 2 diabetes. So on that, I'll turn it back to Terry. Thanks, Terry.
Yes, thank you so much. We don't want to assume that everybody knows what prediabetes is, and that relates to not only the audience that we have today, but also to the employed population. So what prediabetes is when you look at that chart over on the right-hand side, an A1C of 5.7 to 6.4 is one indication. However, even if a participant, a patient has not had their blood tested for an A1C, which is a longer time frame picture that they're looking at, but they do have, say, for instance, biometrics done on site, we can also look at their blood glucose, and if it's between 100 to 125, we can indicate that they are pre-diabetic. This is important to know because we cannot work with those that have already been diagnosed with diabetes in the pre-diabetes program. We can refer them to a diabetes self-management education and support group, but they do not qualify for our program. In addition to that, we have got another way to test them, which is simple, easy, fast. I wish we could get the entire population to go to doihaveprediabetes.org. It's a simple test, and it will look at several factors: your age, your family history. If you're a lady and have had a pregnancy and were identified with gestational diabetes, that puts you at risk. So it's more lifestyle risk factors that we're looking at. Weight, which we know obesity lives in the same house as prediabetes and diabetes. And then, of course, your age is also another one. We also know that in the wellness field, we talk about three big factors that impact all of chronic illnesses: healthy eating, becoming more active, and then stress management is one of those as well. So with that said, we also know that according to the National Institutes of Health, approximately 90% of prediabetes could be either delayed or even prevented with these lifestyle behaviors. We also know that approximately 75% of our medical costs are due to chronic illnesses, and those chronic illnesses include diabetes, but also some of the other diseases such as heart disease. One of my favorite sayings, I've asked Patricia to share hers several times during this presentation, but one of my favorite is we can't have that reductionistic thinking. in the behavior lifestyles, we always look at what are behaviors that will impact a multitude of different chronic illnesses. So we don't just treat diabetes, but when we go to prevent diabetes, we're also reducing the risk of heart disease, possibly even some of the autoimmune diseases such as lupus, even multiple sclerosis can be, the impact of it can be reduced with proper nutrition and exercise. So there's so many factors that we can really look at and impact our employees. We also know that over 1.1 million Kentuckians, and likely a growing number of all of the employees that you represent or that your organizations represent, are estimated to have pre-diabetes. That's a huge number and gives us a target audience that seems a bit unlimited at times. So 1 in 9 people nationally have diagnosed pre-diabetes, which in and of itself can be startling, but more than that, 7 out of 10 don't know it. I think that's why the paper test, here I go again, doihavepre-diabetes.org, in addition to any of those screenings that we might do on-site at our corporations or through their primary care physician, are so very important to identify. We also know that when we have many of these conditions, it puts us at risk for other diseases. And one of the novel diseases that we, of course, were looking at this year was COVID-19. So we would miss a big piece if we didn't talk about the impact of COVID-19. As we went through it last year, and as the Central Kentucky Association of Health Underwriters Conference was canceled and so many other things, I was curious to see how it would fall through for the year, because I knew that obesity and diabetes put people at a higher risk for COVID or having complications with COVID. We heard a lot of that. Well, in June of 2020, and then published in August, was a meta-analysis of 13 different studies. It looked at 4 comorbidities: pre-diabetes, diabetes, hypertension, cardiovascular disease as indicated by a high cholesterol, and respiratory disease. People were 4 times more likely to not only end up in the hospital, but ultimately die as well. So when the numbers for 2021 came out, I really recognized that there were some factors that were input into that. But beyond that, we also knew that there was so many emergency room visits that were already happening. So this is alarming to me that in 2018, there was 15,902 emergency department encounters with diabetes coded as the primary reason. Those totaled $74.6 million. I don't know about you, but I know many places that $74.6 million could be spent. The 2019 data has already come out as well, and you've got this infographic in our handouts. 16,477 with a cost of $92 million. So just in 1 year, our costs went up nearly $20 million. I truly believe that we have got an epidemic of diabetes, not just in the state of Kentucky, but certainly in the nation as well. We also know that it is incredibly common to have diagnosed diabetes in our state. So we look at that national, but we also look at our state numbers. If you look, you can see that the Eastern Kentucky and the Western Kentucky are considerably higher in their rates. However, that doesn't negate what's going on in Central Kentucky and, again, the communities you serve. We also recognize that there's many people that have come in to the area, the Central Kentucky area, that bring their culture from Eastern and Western Kentucky and all of those habits that are so very hard to change. And we also know that many of your organizations have locations within those areas. So we've got those, the lighter blue through central Kentucky, but it doesn't mean that we haven't got the issues there as well. And even when we look at the 9.7 to the 11.8, it can be an overwhelming number. This is the diagnosed pre-diabetes that we've got. And again, remember that 7 out of 10 don't know that they have pre-diabetes. So this isn't even the full picture that we're looking at. When you look again, it's in the eastern Kentucky and also in the western Kentucky. But with pre-diabetes, it's pretty standard across the state. So I'm going to take a breather and give Patricia just a moment to share a few thoughts on the epidemic that we currently have with diabetes and prediabetes.
Yes, no, great information, great numbers, Terry. I think when we look at all this, we have to think, how are we going to stop this train from becoming, if we look at the pre-diabetic population to becoming diabetic. And what I said earlier, we need to do it by replacing health eroding behaviors with health promoting ones, movement, healthy eating, effective stress management techniques, and so on. And I think that, you know, if we really think about it, if you're in a pre-diabetic state, that's reversible. And you could really do things to improve your quality of life. We've talked a lot about cost. We'll continue to talk about cost. But ultimately, I think Terry and I would agree that we're here to help every human to thrive. And we're going to hopefully share a solution with that. Kentucky's health scorecard pales in comparison to the rest of the nation. And, you know, again, we're looking at these numbers where our comorbidities and or mortality result in, again, death rates that are higher than the rest of the nation, disease rates that are higher than the rest of the nation. So just remember, prediabetes is reversible, and diabetes is a lifetime chronic disease. We'll talk more about that later, but I'm going to turn it back to Terry right now.
Thank you, Patricia. I think it's so important that she brought up, it's not just about the disease state, it's about our quality of life. And I always, we have our mantras. Another one of mine is live life with vitality and joy and purpose. And when we have a disease state, it reduces our ability to do that. And we'll talk a little bit more about our value on investment for our core companies later. And that's where that really comes in. Thank you, Patricia. Here are the statistics that I alluded to a little bit earlier, the 2020 increase of deaths from diabetes. Again, what really surprises me here is the number of deaths that we have in diabetes and how it is increasing dramatically over the years. But I have to say, as we went through the year and I waited for those 2020 numbers to come out, this is from the JAMA, you've got the reference down at the bottom there. I expected that because you were 4 times more likely to die if you had diabetes, that the diabetes numbers, the deaths from diabetes, would actually drop to kind of compensate that they were given that death certificate of COVID. We didn't find that to be the case. So you can look here and you can see that the deaths from diabetes just from 2019 to 2020 went from 87,000 up to 101. What a sad state. We know that much of that could have been because people weren't able to go to the hospitals for treatment or their primary care physicians or their endocrinologists. But in addition to that, they were fearful of going to the hospital and to their doctors during that time. There were so many factors that played into it. I still was surprised. And I'm also surprised that from 2015, the deaths from diabetes has grown from 79 up to 87. So even taking out those 2020 numbers, we had a 7,000 plus increase in deaths over 2015. And again, that's diabetes, which we know we can delay or prevent from happening. We want to give you just a few more graphics that really show the problem that we're dealing with and then move into the solution. This is a graph that we like to present to people in many different talks that we do, because again, overweight, obesity, and diabetes tend to live in the same house. The graphs on this page really indicate that. If you look at this top graph, it is showing the obesity rates, and you can see how it's climbing. And this bottom graph is showing the trends in diabetes and pre-diabetes from the National Statistics Report of 2020, which is on your resources page. Don't they mirror each other? With that said, again, we can go one step further and we can look at the growth of overweight and obesity since 1990, with a huge jump in 1976. And before I give you my soapbox on that one, we can also say, look at the increase in our youth. Those that are under 19 are also growing. And as employers and those serving the employers, we should be really concerned about our young population that is getting fatter sooner, moving less, and eating less healthfully. So that's certainly a concern for us. But my soapbox on this is we spent so much time last year in flattening the curve with COVID was absolutely necessary. But I would propose that it's now time to start to flatten that curve, not only for diabetes, but some of the other chronic illnesses. Before I turn it back over to Patricia to share some of her thoughts on that, I want to give you one more visual. And again, this is a slide that I tend to use in a lot of my presentations because obesity is one of the root factors of so many diseases, and we can talk easier about how you can address that obesity, whereas diabetes and some of the other diseases have the additional pieces in it. So when we look here, I'm going to start at the end and then move backwards. This is the 2019 obesity chart, and we should all be asking Colorado what they're doing right. They are the only state that has stayed green over the years. So if we then backtrack, again, here's that 1970 where we were at 15%. We're now at 42.4. But if we look back at that 2011, we had several green states. We had some yellow states. We had some orange states, and we had no dark orange states. Fast forward, you can see that we quickly lost some of those green states, not only on the West Coast, but also on the East Coast. They have now joined the yellow. We can also say that during that time, we've seen the Southern Belt grow north. And in 2019, we've seen the dark orange become so incredibly prevalent. That, I think, for me, states a case for why we need to find a solution. Patricia?
Yes, agreed. You know, and if we look at these numbers, Terry, that you've shared, and I know we've thrown a lot of numbers at the group, but we really want to try to showcase the alarming trend that's happening in our country. And we know we can do better. We know that this is an unsustainable trend that we're on, and that ultimately the burden of care will be too great. And how do we start to offset that? So we do have solutions. I mean, that's the good news. Other than to go live in Colorado, where it looks like the norm is more geared or leaning towards well-being and wellness, and the rest of our country is leaning more towards the illness. So that's a sliding scale that we can do something with. Again, other than going to live in Colorado. But we do have, Terry, some good news, a solution to share here soon with everybody. And I know you've got a polling question to move to next.
Yes, we just opened the first polling question. Are you familiar with the CDC Diabetes Prevention Program? Not everyone has answered, but probably the majority has. And about 57% are aware or familiar with it. And 44% are saying no. We still got interest coming in, but it does look like about 10% more than 10% no, more than 10% that don't. Oh my gosh, can I say that?
Thank you, Deanna. I'm surprised by that, actually, and really thrilled by it. So we can, when we make our call to action to you later, we're going to give you resources, because we know so often, even if people know about programs, they've got to be easy, they've got to be accessible, and they've got to be sustainable for not only the program, but after the program as well. How many times do you know people that have started a program but not finished it? So I am excited that so many of you are familiar with the National Diabetes Prevention Program. And I would also say, we'll get into this a little bit later, but the number of providers that we have located in the Kentucky area is something that we at Kentucky Diabetes Network and the State Public Health Department are very proud of. So the Prevent T2 program is an evidence-based program through the CDC, and they use nationally certified lifestyle coaches. So again, you hear a lot when we talk about lifestyle coaches, because it is important that people are making sustainable changes, not quick changes in their lifestyle. Here you can see some of the initial numbers that we will use to indicate how effective the program is. 58% reduction in the incidence of diabetes. That's taking those pre-diabetic participants and reducing their risk of moving into the diabetes or even just delaying it. 58% of the 5 to 7% weight loss. That 5 to 7% weight loss is one of the requirements and credentials for an organization that's providing the program to stay fully recognized by the CDC. So we'll talk a little bit more about a fully recognized organization in a little bit. We also know that the highest risk group with regard to age is 60 to 64. And so when we take that same weight loss reduction, we know that when we're working with those that are over 60, we've got an even greater success of 71%. We also know that many of those participants now are coming into our insurance programs as retirees or working longer. So we are bearing those costs as employers. We also want to state that 34% stick with their behaviors, and after 10 years, they're still not moving into that next level of diabetes. Why is it working so well, or why does it work so well? We're going to talk about implementation later, and that's a huge piece, is the variety of ways that the program can be implemented. But how they've set up the program is very support and knowledge heavy on the front, and then we continue to support those people through a year-long process. So during the very first 6 months, the groups meet one time per week. And again, we'll talk about the modalities of how the program can be implemented, but they meet one time a week, which really bonds the people, and it gives them a lot of information and support up front. During that time, we're not only talking about those big threes, the stress management, the healthy eating, and the movement, and monitoring all those, encouraging 150 minutes of exercise, the weight loss, and then also we're teaching them things like, how do you grocery shop? How do you do meal planning? So there's a lot of the intricate details in there. During that next 6 months, it's two-phase, and the facilitator can decide how frequently they want to meet. But typically during months 7 and 8, they reduce their meetings to 2 times per month, and then they continue that support through the year, and they finish out the year with 1 time per month meetings during that time. So with all of that said, we can clearly say that the DPP program is evidence-based and will reduce the risk of the employees from moving into diabetes diagnosis. Here you can see that there's a 58% risk reduction with the DPP program, and metformin is only 31%. I think that says a lot. And remember my reductionistic statement, we're not just improving their risk of diabetes, we're also reducing their risk, we're also reducing their risk of so many of the other chronic illnesses. Patricia?
So thank you, Terry. I think the next slide will show that it is sustainable. That's what we're looking for, is not a short-term fix, but a long-term solution. And what's the effectiveness of lifestyle changes over time? So the answer is yes, as evident in the DPP. This is an outcome study, diabetes prevention program outcome study, which indicates we can reduce the incidence of diabetes the greatest lifestyle interventions. Again, moving more, eating healthy, and effective stress management techniques. So the top line, the top solid line is the placebo, or what I call the do nothing strategy. The second one is pharmaceutical intervention. Most people, it's metformin. And then the last one is lifestyle. So really making an intentional effort to improve your chronic condition through lifestyle management. So since the time of diagnosis of impaired glucose, you will see that we bend the trend the most, or we flatten the curve the most through our lifestyle interventions. So help us flatten the curve. Go get your blood check today and find out what your blood glucose level is. And I'm going to go ahead and transition us to our next polling question.
Okay, just a moment. Let me make that live. All right, it is now open. Remember to please refresh your screen, either by clicking enter in the URL or pulling down if you're watching on the phone app. It should be available now. I see a lot of answers coming in.
Thank you.
Still about 100 people need to answer. If you don't see your polling questions, if you're watching on your desktop, it's going to be to the right. If you're on your phone and you've got your phone turned landscape, turn your phone to portrait mode and you'll see it at the bottom of the screen. And I'm answering about 80 questions that I've been sent in different ways with that comment. So yeah, 100% of the people have said yes. If they could cut the risk of developing chronic disease in half, would you?
Right.
Wouldn't it be wonderful if we could get our entire population in the state of Kentucky to be on the same page with us?
Yes.
Patricia, I want to pause for a little bit here. I actually looked at the time and we're doing okay. We still have a lot of data and solutions for you. But you know, when you're in the wellness world and when you're in the broker world, you want so desperately for others to be as passionate as you are about all of these things. But the real truth is we can't make them do those behaviors. So we have to really work to inspire, to encourage, to offer programs that are easy to access. And that is when we see the solution. But it is unfortunate that, you know, we, all of us, are the people that bear the cost of the behaviors that only the employee can actually change. So we do need to do some mindset shifting as well, but we are so excited that all of you are interested in helping us in this endeavor as we go to the solution and really talk about how you can implement programs for your clients. So why would employers choose to cover the DPP program? We've already talked about that cost avoidance or cost savings and how it can delay or actually completely eliminate the onset of diabetes, and that it is evidence-based. But again, it's really important that the implementation is easy and has flexibility. Everybody is a different learner, and we have different touch points, as I like to call them, in the industry, and we need to offer many different modalities, and we also need to touch them several times. I've been surprised at some of the posts I've seen on Facebook from some of the providers at a national level and how eye-catching they are, and that may work for some people, and other people, they'll do better with referrals. So you never know, and the more we can get the information out, the better. And the ways that we can implement it need to be a variety so that we can touch more people. So there are 3 delivery modes. We can do on-site, at the work site, or other locations. We can also do online or distance learning. So the difference between online and distance learning, again, they're all CDC recognized and hopefully fully recognized, but that online are those programs that people are simply on their phone, whether it be a Weight Watchers, a Lark, or any of the other online platforms. They don't have necessarily that face-to-face contact. Distance learning is a wonderful option for people that may have rural participants, or they want to combine a number of groups. So distance learning would be similar to what we're doing. This is actually virtual. And distance, you would have the educator in one place and participants would be in another place. I actually was down in Western Kentucky yesterday, speaking at the Caldwell Medical Facility and talking to them about how do we get people to that Western region where we don't actually even have any providers, because culturally, we want to make sure that we're identifying and speaking to what's available to them. I can't talk as though I'm speaking in Louisville. I need to be able to speak to the resources that they have in that region. So distance learning for some of our rural or multi-location places is wonderful because you can have everybody in a meeting room at the location and then bring in the distance educator. So that's what distance is. Community partners are those public health departments or other providers within the state, and we'll show you a map that you can partner with outside of what might be available through the carrier. So the coverage methods can be the employer covered benefit, where the employer is paying for it directly. This might be seen more with your self-funded groups or your level funded groups, or it may even be with some of those fully funded groups that want to offer a little bit different experience for their participants. Let me just note incentives, incentives, incentives to get them engaged, very, very important. Or it could be an insurance covered benefit. So we have a lot of incredible carriers here. Kentucky Diabetes Network partners with many of them, and they will know what's available for your clients. So that's absolutely your first go-to, is to go to your carrier, speak with your client services, find out what's available, and get that marketing out to the organizations. In addition to that, get some of your own marketing out and possibly partner with some of those community partners. So we won't talk directly about the contracting party. You can go completely with that, contract directly with the CDC recognized organization or a third-party administrator. Let me just make a note on this too. This has come from the Brokers and Consultants toolkit from the CDC, which you've got a reference for on that document that I uploaded. Here we've got some of the employers that cover the diabetes prevention program in the state of Kentucky. This again is from that coverage toolkit, so it's not inclusive of the many organizations that have participated in the DPP program, of which I'm going to turn it over to Patricia, who's going to share not only a success story of one of the largest employers, but also the success that her organization had with the DPP program.
Yes, and well, you want to, okay, you showed the participating health plan. So, gosh, there's nothing like a good success story to inspire us all, right? It can be so powerful. And I want to thank Kentucky Employer Health Plan for sharing their success with us and willing to share their case story. So a little bit about that. They implemented their program in 2014. It was started initially with Humana as their third-party administrator and the YMCA as the sole provider. They were one of the first state health plans in the nation to offer free enrollment in the DPP. And the reason, part of the reason that they, well, I think majority of the reason that they rolled this out was they were looking at the very bottom quote, at least 85,000 members were at high risk of developing type 2 diabetes. And we know that once you are diabetic, the cost can go up significantly in diabetes management and potential diabetes issues related to it, like going blind or having a foot amputation, cardiovascular disease. So they had to do something to really figure out a way to stop the train, right? We need to stop that train from becoming pre-diabetic to diabetic. So they rolled the program out. And next slide, Terry, thank you. And this is some of the numbers that they shared. One of the first pilot projects was the Ashland pilot. You can see also in the second pilot that in both situations, people lost weight and they increased their physical activity. Through the success of their pilot, they also expanded that program in 2014 with more geographical reach across the state and an increased participation in the classes. And today, they now, again, because of that success, they now offer the program to all qualifying members. I think that key factors to their success, and Terry and I talked about this a little bit, was the integration. They integrated the diabetes prevention program into their wellness program and gave people points rewarding them for completion of the program. So they could also, in addition to what the support they get through the program, they also could convert those points to bucks. They could use them to redeem gift cards and fitness devices. So those are all good things that help keep people engaged, especially when you're talking about a year-long program that meets in the first 6 months every week. The other key was collaboration, not just collaboration within their organization, but collaboration across the state with other agencies and community-based organizations to engage, to help get the word out, as Terry just said, to help get the word out. If people don't know about something, they can't get involved with it. So marketing efforts really come into play there, word of mouth, and really trying to work to engage folks in those programs. And those are two critical, important elements to consider when you're rolling out the DPP program. So we've talked a lot about return on investment, but the next slide, I really want to talk about value of investment and your quality of life. We often talk about ways to help people to thrive. And here's an example of a husband and wife team that teamed up to achieve their wellness goals. Howard Osborne is a retired superintendent and KEHP member, and credits his participation in the DPP with adding years to his life. He lost 50 pounds, he's moving more, he's more mobile, enjoys fishing, mowing the yard, and taking family vacations. And I really like that he also gives credit to his spouse, Linda. He said that she got involved, and between the two of them, they lost 80 pounds. So they're living a healthier life, looking forward to watching their grandchildren graduate. And don't we all want to do that? So congratulations to them on a life well lived. The cumulative impact of the program is the next slide. So I want to share KEHP's numbers here, a total weight loss of 2,313 pounds, a cumulative average weight loss of 4%. And you can see the physical activity, cumulative average physical activity, and then the 44,298 for total physical activity. A1C numbers, the ending average at 5.69. Again, great story, great job, KEHP. We need more organizations putting this program into place and having the success that you all have had. So congratulations to them. Real quick, I will mention again, just for the sake of time, that we rolled this program out at U of L when I was there. We had similar results. We started with the pilot program, and that we slowly were integrating it in. We partnered with ULP Diabetes and Obesity Center with Beth Ackerman as the lead facilitator. She is a certified registered facilitator. And again, great numbers, great result, which is why we want to get you all engaged. And I'm going to pass it back to Terry for our call to action.
You might have seen me just kind of go, yes, Beth Ackerman. She is the president of Kentucky Diabetes Network. And so she was, I actually started working with her in the diabetes prevention program as a co-chair lead of that group several years ago. And she's so wonderful to work with. So here's our call to action to each of you. If indeed,
Terry, I'm sorry, this is Deanna. I hate to interrupt you. Before you go to your call to action, I just wanted to remind everyone the third polling question is now live. We've got about half of the folks in attendance answered. So please take a moment to answer that final question, and I'll give it back to you. Thank you.
Thank you, Deanna. So we do want to make that call to action, and I cannot be passionate enough if I was jumping up and down, screaming, yelling, whatever it is, to get you to really recognize the importance of this. And we know there are so many programs that you roll out to your clients, but this one, again, can be something that, given the many opportunities to implement it, it should be a program that's offered to every single person in the state of Kentucky. And we know that much of that happens through Medicare and Medicaid, but then also through the employee base. So we all typically are one of those three, and hopefully you can help us get the information out to employees. So here are some of the top motivators, and we have talked a lot about the medical costs and reducing those risks, and we've touched just briefly on those other motivators. And that's that value on investment. That's that quality of life. That's showing your clients that you care not only about their success, because every company hopefully puts benefits in place to enhance their employee population, whether that's with recruit and retain that talent, all the way down to reducing that absenteeism and creating a culture of well-being. And again, I would be remiss if I didn't give Patricia a moment to speak about the culture of well-being as well.
Yes, no, thank you, Terry. I appreciate that. And again, with the understanding that these motivational, the top motivators, cost savings, reduction of employee health risk, reduction of overall health costs, improvement of employee all these motivators were things that I was looking for when I was at U of L, from the brokers, from the people that helped consult with me on my program. And what I want to share is that this is what your clients are looking for from your experience and your industry insight, and that you can count on the DPP to deliver. It is proven, it is evidence-based, and as Terry said, it will help support a culture of health and well-being within your organization. We talk about wellness, it will help build trust within the organization, and it will help every employee to thrive, which will then help the organization to thrive.
Thank you, Patricia. In addition to that, we can talk about the cost of insurance to not just the employer, but also to the employee. And I think so much of the responsibility is turning to the employees, that now we have an opportunity to give them some of the responsibility back for their behaviors and therefore their disease or health state. So this was published by the Kaiser Foundation in 2019, and I know I used this one for another presentation as well, but you can see that rising cost. And again, let's flatten the curve, and you can see how unsustainable it is that we have gone to such a high cost, from $13,000 to $20,000, and that's just the employer share, but even the employee cost has gone up dramatically over the years. That should be a selling point, not just to our employers, but they should be sharing that information with their employees and helping them to understand the role that their health and their behaviors have. And we know that there's so many other factors. You know, are they using a primary care physician versus using the emergency room? Are they getting the best price on not only any of their surgeries, but also their prescriptions? Those all come into play. But if we look at the base core numbers and look at what it's costing as far as their premiums, we can do a great job reducing those numbers as well, and giving both the employer and the employee an opportunity to understand that. So here are some of the key points. And again, we've given you some resources, that toolkit for the brokers and the consultants. And there's also an employee toolkit on that site that you can access. But we know that you are so important as you're going out and you're talking to your clients day in, day out. You're listening to what they're saying about how the rates are going up, how the health of their employees is going down, and they're frustrated. You can give them a solution. I can also tell you that, again, this is not a reductionistic program, and more people than you might think would qualify for the DPP program. So it's important to get that message out and even frame it. It's not just about diabetes, and some of the programs are talking about weight loss as their header, and then talking later about the diabetes. Marketing is key. So within that, we also want to, as Patricia mentioned, make sure that it's strategically implemented into a comprehensive wellness program and a culture of well-being. This shows you those partnership options. So again, I want to remind you, we talked about implementation can be digitally or online. It can be completely virtual, distance learning. It can be in person, and it can also be in person through those public health departments and through some of the other providers, such as Baptist Health, I know is one of the clinical organizations that's already covered. Look at all the resources that we have within the area. Again, I've provided for you the Lexington Fayette upcoming class. If your people want a different option that's within the community, want to take their family with them, it's a great resource to be able to provide. Again, giving them the options that their carrier has given them, that their wellness program has given them, and that the community offers can be a trifold to get to the result that we want. So I think it's really important that we continue to promote some of those community programs that we've got out there. Here's a list of the community partners. You can see that they're listed by pending, preliminary, and fully recognized organizations. So what a fully recognized organization is, and let me just say the state of Kentucky is really proud that we have so many. We need to start using them. So what a fully recognized organization is an organization that has met that criteria, that 5 to 7% weight loss, that 150 minutes of exercise, reduced the A1C, retained their participants. There's quite a few credential or criteria that you need to meet to hold that fully recognized credential. So again, we have got so many in the state of Kentucky. Some of them are working directly through the carriers and others are working through the community, and just another resource for you to have. It is absolutely a mindset of prevention, and I am going to let Patricia close us out here.
Thank you, Terry. Yes, we talk so much about how important it is to build a culture of well-being, whether it's in the community, corporate environment, or campus. And I think that the DPP program helps you to do that. It promotes well-being. It is a participation-based program, which means that it's not necessarily based on the outcomes. It supports a positive framework and a foundation for positive health outcomes within the organization. We all talk about, especially after COVID, that it's really important that social isolation and depression, and this can offset that. Prevention offsets that. This program helps build a sense of community and helps people to engage and with each other again. So again, that mindset of prevention is not waiting until we have diabetes, but in this case, honing in and putting solid programs in place that we can intervene with at the pre-diabetic state.
So there's you're ready to get started. Fully funded, check with your carrier, your benefit consultant, level and self-funded, check with the community partners, engage in those programs, check with your benefit consultant, and everybody go out and take the self-assessment testing. It has been such a pleasure partnering with Patricia today to present this, and many thanks to the Central Kentucky Association of Health Underwriters and Deanna.
Oh, go ahead. I'm just let you finish. I'm muted for the questions. I'm sorry.
Awesome, great. We'll be at questions in just a second. So do download that handout of the diabetes resources available to you. And also feel free to email me at any time at kentuckydiabetes@gmail.com. What I've put up here is a meeting that we have on Friday. This is our KDN quarterly meeting. Kentucky Diabetes Network does 3 things yearly during a different amount. We have our research forum, which is looking at some of the research that's happening during the state. That's done quarterly. We have our yearly symposium, which is educators that are looking, that are primarily licensed ADCES, which is the diabetes educators. And then we have our quarterly meetings, which are geared for people like you, people like those living with, or not like, those living with diabetes, the educators, really for the entire community. So our program is this Friday, and we have got 3 presenters. We've got a container gardening presentation. And then we have got a healthy meal preparation with nutritional tips. And then we have got Glean Kentucky, which utilizes those resources because we know that food insecurity, even for those that are working, can be an issue, particularly in some areas of our community. So we'd love to have you join us. I do have the link there. You can also email me, and it is in your resources as well. We'd love to have you on an ongoing basis. One of our goals with the Kentucky Diabetes Network, as I mentioned, and the STEM project that Patricia is helping us with, is to increase the employer and the carrier participation in these programs. All right, Tiana, thank you.
Sure, we've got just a couple minutes and then we'll jump into our stretch break session that you're leading. So that's great, but we do have some good questions. How does the program identify those in need and how those are identified, contacted? I think you've addressed that earlier, but do you want to high level hit that?
Yes, high level hit us, help us. There are many ways that people can hear about the program. Our I have prediabetes.org takes them to the CDC site that will recommend different providers. But again, I think the message is so much stronger when it comes from a variety of areas, including the employer and an employer provided benefit when they truly see it as a benefit. So do help us get the word out. It is difficult to get the message to the number of people. We did a campaign with United Healthcare that we did Do I Have Prediabetes.org billboards. And we also did several pieces on the radio station. So we continue to do those type of initiatives, but we really need your help.
Great. What if you eat well, are a runner, have a normal BMI, no history of diabetes, manage stress, are under 50, but are still pre-diabetic? What could be the other causes?
Yeah, that's an interesting question. During our last research forum, we had several speakers, and one of the speakers, when she sent me her slide, I looked at it and I said, mystery? Well, that's her story. She, genetics does play a part. And, she was the least likely to be identified with pre-diabetes. And so she upped her game a little bit. And I do believe she ended up on medication plus lifestyle. And again, even if we can delay or reduce the risk, that's good. So I'm not saying it's 100% behaviors. There is that genetic component, just like there is with cholesterol and cardiovascular disease. And there's so many other diseases that we deal with as well. So yeah, I'm sorry he is experiencing that, but it does happen.
I was going to say, Terry, you're right. This is really just the general information for general public, and it probably covers most people. But genetics, we can't control genetics. The genes we get, and certainly I want to commend that person from taking proactive steps to manage that situation. And I hope that they certainly get answers, because that would be a tough one.
Yeah,
to have to deal with.
Definitely.
I have the recording from that person. I'd be happy to share it with anyone that was interested in that and how she addressed that factor.
Okay, so that person asking the question can just reach out to you via your contact information and get that if they're interested.
Absolutely.
I think that ties in with the genetic thing that someone's asking. They were diabetic, lost weight, pre-diabetic. Both grandmothers passed away with diabetes. Are they always going to be pre-diabetic?
Let's hope that they stay pre-diabetic versus diabetic would be my first answer, but you can reduce even further. Again, he is swimming upstream, and I often share in my story that I was dealt a really bad hand of genetics. I've actually outlived my mother, and I'm quickly about to outlive my father. And, I can do what I can do. I don't have any chronic illnesses at this point. So stick with it. Recognize again that it's not a reductionistic, that our quality of life is greatly improved. And the longer we can delay the onset of diabetes, the better. But you can get even below the pre-diabetes numbers. There's a lot of research on that. It just takes diligence and consistency. Patricia?
Yeah, no, I agree. Terry, great feedback. We're staying involved with your clinician as well. I mean, that becomes a clinical management piece. So we're not clinicians, but we certainly can help advise people on lifestyle. So no, I think it's great that people, great questions.
Mm-hmm.
All right, last question. We're running out of time, but these are really good. And for everyone that's listening, if we're going to go into the stretch session after this question, and then take a minute, grab something to drink, be sure and stretch, and be right back as quick as you can for our next session. But the last question is, what are the best resources for defining what constitutes a healthy diet? Some things are obvious, but several trends, plant-based, fasting, keto, seem to be confusing. So what is healthy?
Goodness, that is a loaded question. And I'm going to give Patricia a moment to speak about this as well. But I say, let's find the commonalities and quit arguing. And that's another one of my favorite statements. And, you know, I have my opinions, other people have their opinions, but here's my top 5. Whole foods. Again, remember that jump from 1976 to Whole Foods. How was it created? It didn't come out of a package unless it was packaged whole, like rice. So Whole Foods, half your plate, fruits and vegetables. Such an easy concept to say, but not so easy to implement all the time. Increase your water, which naturally decreases your sugary drinks. Move. And eat mindfully rather than emotionally. Beyond that, let's not argue about where we're getting our protein from or any of those macronutrients. I would say stay away from fads, but if you're filling those 5 components, you're probably at least improving your health benefits. And is it sustainable? Patricia?
Yeah, and I'm just going to summarize it up in one sentence. For the general population, I've always said eat a wide variety of lightly processed foods. So you're right, lightly processed, you cannot get it out of a vending machine. I was at the hospital yesterday with my sister, and everything in that vending machine, I needed a little snack. I didn't get any of it because it was Snickers and chips and you know, none of that stuff is going to give me energy. So it might taste good going down, but I know in the long run, it's going to be to a detriment. So again, microscopic behavior. Eat a wide variety of lightly processed foods and you're going to be fine.
Fantastic. There are a couple of questions which we don't have time for. If one of you ladies want to go back in and answer those via the Q&A section from the Whova app. Patricia, thank you so much. Terry, thank you so much. We're going to jump right into our stretch session because I don't know about everybody else, but Deanna needs it because she's been sitting at this computer for hours. So,
Deanna, do I need to get out and back in?
You do. You need to use the link I sent you in the calendar appointment.
Got it. See you in a minute.
Thank you.
Thank you, everybody.
Thank you, everybody.
Thank you, Terry.